Hello everyone, I am Ritu Sahani. Today we are here to discuss about the pelvic region. But before going to pelvic region, it is important to understand that what are the attachment which influence the function and the dysfunction of the pelvis related to the pelvis. Because today we are going to learn more about the pathomechanics, biomechanics, anatomy, and as well as the clinical evaluation assessment about the pelvis from Dr. Senthil P. Kumar sir. This is the great opportunity we are getting that we are going to learn more about the multistructural dysfunction like the articular, myofascial, and neural in our workshop, which is going to be held in Delhi in 16th and 17th December. For that, we are going to learn with the pre-congress webinars for our preparation about the AMNMT. For this, today's our topic is the pelvis, but we know that the region that is, and this is the model which I have received today, and this you can see that pelvis, the superiorly it is completely attached with the lumbar spine. It means that lumbar spine function can influence the pelvis through the sacrum, which is the base of our spine, where you can see this, and in the back you can also see there is a coccyx. So lumbar spine, sacrum, and then there is a coccyx that is called as the tailbone. So, and this the attachment of the lumbar spine with the pelvis, because we know this is the flat bone that is known as the ilium, and this is the in back side, this is the hard bone in which the body sits, like the ischium, this is the hardest bone, and in anteriorly there is a pubic symphysis. So this is the ring shaped structure that is for when we treat or we learn about the pelvic floor dysfunction, then we see that what are the dysfunction related to pubic symphysis. And whenever we talk about the sacrum and ilium attachment, there is a sacroiliac joint, that is the synovial joint, so that give the mobility to that joint, and this sacrum attached to the lumbar spine. It means the lumbar spine extension and flexion also influence the nutation and the counter nutation of the sacrum, because whenever the sacrum is going in the flexion position, that is the nutation we say, and when it comes in the extension, so it is known as the counter nutation, and it works opposite to the lumbar spine. Like when the lumbar spine is the flexion position, then our sacrum goes in the extension position, and when the lumbar spine is in the extension position, that time sacrum goes in the flexion position to maintain the lordosis. So this is the way sacrum, and even when we rotate the lumbar spine on right side, sacrum rotates towards the left side, and when the lumbar spine rotate to the left side, the sacrum rotate to the right side. So this is the opposite direction they works. So this is the, and in between you can see in the lumbar spine, anteriorly there is a intervertebral disc, vertebral bodies, and with that there is a attachment with the pedicles, and there is a transfer process, and in posteriorly you can see that there is a spinous process, and they with the lamina they are attached with the facet joint, the superior articulate process, and the the superior articular process of the inferior vertebra, and the superior articular process of the inferior vertebra. So they both are articulate with each other. So this is the facet joint. So because of that rotation, sometimes the facet joint dysfunction comes in the picture, either in the extension lock or in the flexion lock. So this is about the vertebra, and in between there are the ligaments. They are also attached with the ligament, that the spinous process itself attached with the supraspinous ligament, infraspinous or interspinous, and in there the facet joint, in between there is a transfer ligaments, and in between the vertebral body the ligamentum flamum is there. So there are so many ligaments which attach and which give the stability to the lumbar spine, and from lumbar spine to the ilium there is a ligament, iliolumbar ligament, and from the sacrum the ligaments give stability to the ilium, that ligament that is attached with the ilium. So that spinous ligaments, and the tuberous ligaments which attach with the ischial tuberosity to the sacrum, or with the pubo sacrum with the pubis attached to the sacrum, and there are ligaments which give the stability to the femur bone, to the ilium, ischium, and pubis symphysis, that is there are also the ligaments which give the stability. It means that the structure, it works on the ligament stability. So we can see that because of their ligaments and the joints, after that we can see there are the myofascial structures which give support to the lumbar spine, to the innominate bone, because their attachment, their origin to insertion, there are the psoas major and minor. They are the, because they are crossing this hip joint, and they are the inserting in the lesser tuberosity. uh, in that you can see that they are the hip flexors, and there is the iliacus, from iliacus to, that is also going to insert here. And as well as there is a quadratus lumborum, which is the lateral flexor of the lumbar spine. And in posteriorly, and beautifully it is made that the gluteal region, where the gluteal maximus, minimus and medius, which are also inserting in this innominate vein gluteal tubercle. And as well as there is a piriformis, that is in between the muscles, and there is a gamellae muscles, and you can see it here. And behind this there is a neural component, the nerve, the foramen for the sciatic nerve, that is their sciatic nerve is coming. So if there is a tightness of the piriformis, so it compresses the sciatic nerve. So we know that the symptoms like pseudo sciatica or the true sciatica, which is either coming from the from the sacral plexus, where from the L5S1 radiculopathy, or as well as the pseudo sciatica, which is the symptoms of the piriformis, because its attachment is in the posterior side. So this is for the extensor and the external rotator of the hip also. So this is the sacrum. And there are the dysfunction related to the sacrum torsion, or the unilateral or bilateral sacral movement, or as well as the rotation of the lumbar spine influence the sacral rotation also. So we know that how the behavior of sacral and lumbopelvic rhythm works together. In that we can check it. And after that we move towards the uh, dysfunction related to ilium, where the innominate bones plays a very major role, where the lower limb activity influence the ilium dysfunction. Because we know there is the functioning related to the innominate bone, the hip flexion and hip extension. Like in the hip is in the flexion position, that time the posterior tilt of pelvis. And if there is a extension, so anterior tilt. Or if there is a upslips and downslips, where the adduction and abduction force plays a major role. So if the hip is in abduction position, it will go in the upslips. And if there is a adduction force, so it will go in the um, downslip. So upslips, downslip, as well as the inflare and outflare is equal to the anterior rotation and posterior rotation of the hip. If the pelvis is anteriorly rotated, it means the inflare, and the outflare. So this is the medial lateral way we can check the inflare and the outflare. So this is the way the upslip, downslip, posterior or anterior rotation, pelvic, the tilt, anterior pelvic tilt we can observe with the, because with the innominate dysfunction. So it means it is completely understanding about that how the when the sacrum is moving on the ilium, so it creates the ilium dysfunction. And when the ilium is moving on the sacrum, so that the sacrum dysfunction comes. So these are the joints, according to their movement range of motion availability, they works on each other, and they compensate with each other either through the articular structure, myofascial, and as well as the neural. Because we can see that there are the nerves which are coming from the lumbar sacral and the neural sacral, which are going in the femoral nerve in the anterior aspect, and the posterior sciatic nerve, medially obturator nerve, or the lateral cutaneous nerve. So these are the structure as a neural form. And the myofascial structures, we know that the muscles, flexors, which are coming here, and the hip extensors, where the hamstring plays a very major role whenever we talk about the posterior side, where the hamstring plays a major role. According to their medial and lateral head, the hamstrings are there. So they are tightening overactivity, or there are the muscles which are going through here in the anterior aspect, where the uh, quadriceps muscle, which plays a major role in the strengthening of the knee. So this is all about that how the pelvic movement influence the lumbar spine, or as well as the sacrum, and all also in the innominate bone. So this was the great model by which we can understand that how we can give treatment to the articular structure, or as well as we can treat the myofascial structure, and as well as we can give the neural mobilization, the nerves which are going in the anterior, posterior, medial and lateral, and the pubic symphysis dysfunction also in if there is a superior or inferior the pubic symphysis, or there are the pelvic floor muscles which is also related to attach to the uh, pubis to coccyx, pubis to rectum, or the pubis to sacrum. So these are the muscles also like levator ani which pull the pubis symphysis, the pelvic floor up. So these are the muscles also we can treat. We can treat by the myofascial release of pelvic floor, and we can give the articular and as well as the neural, where the neural or loading is or offloading we treat. So this is the way we can understand by this model also. So thank you so much, sir, for giving me this model for my better understanding related to the pelvis. Thank you, sir.